From the JAMA Network, this is JAMA Cardiology Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinion featured in JAMA Cardiology.
Hello, and welcome to our listeners from around the world. You're listening to JAMA Cardiology Author Interviews. Thanks for joining us. I'm your host, Dr. Robert Bonow, the Editor-in-Chief of JAMA Cardiology, and today we're speaking about clinical outcomes with personalized accelerated physiologic pacing in heart failure with preserved ejection fraction. And I'm delighted to be speaking today with Dr. Margaret Infeld, who's an assistant professor and electrophysiologist at Tufts Medical Center in Boston. Welcome, Dr. Infeld.
Thank you very much for having me, Dr. Bonow.
We're interested in having this discussion, Maggie, because you've come forth with some longer-term data from an initial clinical trial that you published in JAMA Cardiology 2 years ago in 2023 called the myPACE randomized clinical trial, which gathered lots of interest. And now you've come back with some longer-term 3 to 4 year data looking at outcomes in these individuals. So this has got, I think, great interest because although it's a study of pacing to increase the resting heart rate in patients, it probably has other implications beyond just these individual patients with physiologic pacing, as we're talking about how to manage patients with heart failure with preserved ejection fraction, or HFpEF. So this is a clinical trial of HFpEF, and I think it's got really important implications. So Maggie, first, I think it would be important to discuss with our listeners what the myPACE trial was all about and what those initial findings were back in 2023.
Absolutely. So the myPACE study was a proof of concept study evaluating resting heart rate in patients with HFpEF. Throughout my training, I had always been taught that slower heart rates are better in these patients to try to increase diastolic filling time, a concept that never quite made sense to me. In my fellowship, I benefited from excellent mentorship from both heart failure and EP clinicians who were Dr. Marcus Meyer, Dr. Daniel Lescarton, who were jointly working to evaluate heart rates in HFpEF. And so the concept originally started by looking at beta blocker use in HFpEF. Our group did a number of epidemiologic studies that showed that perhaps beta blockers are not as beneficial as we thought in HFpEF, hypothesis-generating studies. And then the myPACE study was taking 100 patients with HFpEF with pre-existing physiologic pacemaker systems, which means that they don't induce RV desynchrony during pacing. And we randomized patients to either keep their resting heart rate at the standard 60 beats per minute or elevate it to a more personalized resting heart rate based on an algorithm developed by Marcus Meyer. We then followed them for 1 year and we evaluated quality of life as our primary outcome measured by the Minnesota Living with Heart Failure questionnaire, and then secondarily looked at NT-proBNP, patient activity levels detected by the pacemaker, and AFib burden. And all of those outcomes improved with moderately accelerated pacing compared with the standard 60 beat per minute pacing.
Yeah, we found those data to be very interesting and worthy of getting out there in publication, which is obviously why we did publish this 2 years ago. What was the difference in the resting heart rates between the individuals in the control group versus those with the accelerated pacing?
It was just a 10 beat per minute difference. The control group had a median heart rate, which is continuously monitored by the pacemaker, of 65 beats per minute. And the myPACE group had a median heart rate of 75.
And as I recall, these were people with advanced age, average of 75. And kudos to you that you recruited 50% women.
Thank you.
But I guess if you're doing with the HFpEF populations, you're going to have exactly that type of demographic.
Mm-hmm.
Any difference between the men and women in the improvement in the Minnesota Living with Heart Failure questionnaire data?
No, in our subgroup analyses, there was not a difference.
Okay. And so that was the baseline here, where we found that the quality of life was improved, but you also had some objective data suggesting there could be more to the equation here, in that the N-terminal proBNP levels were also lower compared to the group that was a control group. And then he also looked at other indices as well regarding their activity level and the incidence of atrial fibrillation. So I think that was a good inkling that further longitudinal follow-up in these individuals, which we're now going to be discussing in your current paper that we're publishing now in JAMA Cardiology on the extension study, makes sense. So Maggie, before we get into the new data you've got, what do you think the mechanisms are here? Why do patients feel better and have lower BNPs when they have a higher heart rate?
We don't exactly know the mechanism of benefit, something that we're interested in honing in on a little more now, but the fact that there have been a whole number of invasive hemodynamic studies during atrial pacing in HFpEF patients at rest that showed decreased left ventricular end diastolic pressure and decreased left atrial pressure when pacing at higher rates up to a certain point, and then it starts to deteriorate. But there seems to be a sort of sweet spot, and we think that the mechanism of benefit is a kind of chronic decrease in filling pressures, as was seen in these acute hemodynamic studies, and is supported by the fact that the NT-proBNP decreased after a month. But I would love to dive a little deeper into the mechanism of benefit.
Well, actually, while we're here, I was going to ask you about the mechanism and how we could unravel that
Yeah.
in these patients. So is there changes in remodeling in either the left atrium or the left ventricle? Anything else that could be a signal here that we're already beginning to unravel?
Yeah, so I would hypothesize, just based on the NT-proBNP decreasing and these acute hemodynamic studies, that pacing, even at a moderately increased rate, is offloading the left ventricle and the left atrium. And as we know from the CHAMPION study and some other studies that target the final common pathway of HFpEF as left atrial hypertension, this even like 2 millimeter mercury difference in pressures over long times can have a real impact in terms of heart failure hospitalizations and heart outcomes. And so one thing we think is that a possible mechanism of benefit is that by pacing slightly faster, you bring these HFpEF patients from the steepest part of their end diastolic pressure volume curve down a little bit towards the more linear part. And every heartbeat every day, that is decreasing LV end diastolic pressure. It's decreasing left atrial pressure, which we know is a nidus for AFib when there's stretch and pressure in the atria, and it can decrease upstream pressures like in the pulmonary vasculature. So we think that if you beta block the heart rate down, you're kind of positioning the patient with a stiff ventricle in the exponential part of the end diastolic pressure curve. Pacing a little bit faster to decrease a little bit of volume will exponentially decrease the pressure. So we think that's one benefit. And then Marcus Meyer at the University of Minnesota, who's really pioneered this concept, has done animal studies where he did see some really interesting cardiac remodeling benefits. And we replicated those to a certain extent in a post hoc analysis of myPACE patients that had a convenience cohort of available echoes. And we found that long-term pacing decreased the LV mass to volume ratio and LV thickness.
Well, that's really interesting. And so I'm glad we had that little sidelight conversation, because the mechanisms here are quite interesting. And as you pointed out, a little bit counterintuitive to what we've been trained to think about, the slower heart rate perhaps improving the diastolic filling time and so forth. But I think we're getting more into a new thinking about the possible benefits of higher heart rates. And in fact, that's kind of where we're going, since we are going to be talking about heart failure outcomes in the current study. So let's go ahead and talk then about the current data.
Absolutely. So this extended follow-up study was tracking patients for 4 years after randomization. And we were not powered in the original study to really assess clinical events, but with longer time on the therapy, we were able to do this. And so our primary outcome was the accrual of first and recurrent adverse clinical events. And these included urgent visits or hospitalizations for heart failure or atrial fibrillation, myocardial infarction, stroke, or death. And this was assessed both using an intention to treat analysis and a per protocol analysis. We also looked at event-free survival in both analyses. And what we found was in the ITT analysis, there was, in terms of raw data, about a 50% reduction in all events in the myPACE group compared to control. But because of the small number of events, 15 versus 33, it did not reach statistical significance. In the pre-specified per protocol analysis, 87 patients remained on their assigned heart rate setting over the follow-up of 4 years. And in this per protocol analysis, myPACE was associated with a slower accrual of clinical events, 5 versus 33, and a longer event-free survival. And this was statistically significant.
Yeah, that was really, I think, interesting observations. And the endpoints that you found were driven primarily by heart failure hospitalizations. Kind of gets back to your original hypothesis about what may be going on with the left atrial and pulmonary venous pressures. The editors talked about this too, and we realized, the intention to treat analysis is kind of the coin of the realm when you're talking about a randomized clinical trial and the follow-up. But in your case, you allowed the patients to choose whether they would stay on the randomized arm of the treatment or crossover. And so many people went either direction. So what we have in the outcome are the patients who decided to stay with the original grouping over the course of time. What happened to your numbers when that happened? Did you lose many patients who then had crossed over and were not included in the per protocol analysis?
Not many. So we went from 100 in the intention to treat to 87 in the per protocol. So we didn't lose as many as I thought because this was a novel therapy. And as an electrophysiologist, I'm always worried about pacing people too much in the ventricle, although we did select very carefully for this proof of concept study for patients that only had cardiac physiologic pacemaking system. So hopefully, any benefit of a higher heart rate wouldn't be offset by desynchronous pacing. But we always want to first do no harm. So I sort of thought when we were, the 1-year study exit visit that most people would want to turn back to 60, but so many people reported feeling improved and they wanted to stay at myPACE. And so then we said, well, we have to follow these guys to make sure this is safe. And so in the usual care group, we really said, until all of our trial results are done, we don't recommend that you go to myPACE unless independently it was decided with their longitudinal physician that that would be best for them. 3 people did that. All 3 felt better and remained at the myPACE rate. And then of the 12 myPACE arm patients who transitioned to usual care or 60 after the trial, 4 pretty immediately felt worse and wanted to go back to the myPACE rate. And so because it was such a small proportion of time that they were off treatment, we retained them in the per protocol analysis. And then of the remaining 8 patients who switched from myPACE to usual care, 4 weren't really sure if they felt better or not. Among these 4, 3 had events and only 1 had no event. The other 4 switched due to clinical reasons, and of those, 2 passed away and 2 had heart failure events. All of the people that switched from myPACE to usual care had the events that were included in the ITT analysis, somewhere between a median of between 180 to 500 days after switching to usual care. So it wasn't immediate.
Yeah. So important bottom line here is that the patients who are on the advanced pacing rates with physiologic pacemakers have a better clinical outcome and really significant differences in that per protocol analysis. It's a small number, and these are obviously very highly selected patients because they not only have to have well-documented HFpEF, but they also have to have pre-existing physiologic pacemaker systems in place. Do you think this is potentially something that has more generalizability to the HFpEF population, either with pacing or discontinuing beta blockers? Because there are other data out there that you've discussed already and others that have shown that either decreasing or discontinuing beta blockers in HFpEF patients leads to better clinical outcomes in terms of at least symptom improvement.
Oh, definitely. I think that would be the do no harm. That would be the way to do it, is to de-escalate AV nodal blockade in patients who don't have a strong indication. We know from a lot of contemporary studies that 2/3 to 60 to 80% of patients with HFpEF are on beta blockers. And perhaps because of the kind of paradigm that slower is better. But I think a really good way to apply the data from myPACE is to de-escalate the beta blockers and calcium channel blockers if possible. The one issue with that is about up to 60% of patients with something like 40 to 60% of patients with HFpEF have a concomitant atrial arrhythmia. And so that possibly explains why so many are on beta blockers, because there's a shared pathoetiology of HFpEF and AFib with this left atrial hypertension.
Yeah, very good point. Well, would you choose perhaps even a different rate control pathway here instead of a beta blocker?
Yes, there is some data that folks do better with calcium channel blockers because there's some more use dependence with those. So they work a little less well at slower rates and better at faster rates when you want them to work. But of course, if people have arrhythmia-induced cardiomyopathy, then they would be indicated for a beta blocker to try to improve their ejection fraction. So the devil's kind of in the details with individual patients, but there is some more data coming out that managing AF with calcium channel blockers, and also from some of the seminal AFib papers, liberalizing, allowing a more liberal heart rate when an AFib targeting less than 110 as opposed to less than 80 is beneficial. And perhaps it's because so many of these people also have HFpEF.
Yeah, great thoughts. Okay, what are your next steps now? You've laid the groundwork for interesting things that one could do. And one would be, are you considering enlarging this now to a larger prospective, maybe multi-center clinical trial, just to kind of nail down the overall generalizability?
That would be my goal. Is at Tufts, we're planning for a more mechanistic study, because the study I would love to do is a larger multi-center replication of myPACE that really validates and replicates the data that we found in our small single center study that could be applied to more than just putting pacemakers in HFpEF patients, but is really focused on the heart rate question, whether that be achieved by de-escalating AV nodal blockers, pacing in patients with an indication, or something like cardio-neuroablation, where you might be able to augment heart rate that way without putting in a permanent device. So my next questions are, what's the optimal pacing rate in individuals? And can we maybe leverage AI to predict some of these things to more really personalize for different phenotypes of HFpEF? Who benefits the most and the least? And again, validating myPACE with larger multi-center studies. I'm also very interested in the mechanism, what happens to the pressures over time with moderately accelerated pacing, and what happens with the structural remodeling. Does it level out, or does it continue to dilate the left ventricle? I think these are all really important questions before a pivotal trial.
Yeah, really interesting, especially how to choose the patients for the trial, because as you point out, AI could be very useful here, given the heterogeneity of patients with HFpEF and all the underlying comorbidities they have. And so, an AI process to identify which patients are going to be the ideal candidates for higher physiologic pacing would be of great interest. But I just want to underscore the fact that this was done when you were a EP fellow at the University of Vermont before transitioning to your current faculty position at Tufts Medical Center. So kudos to you for really insightful observations and planning of a clinical trial as a advanced EP fellow. So I suspect that you're going to be continuing to do really interesting work going forward, Maggie. And thank you for speaking with us today.
Thank you so much, Dr. Bonow. I have to definitely give credit to the environment of support for early career researchers at Vermont, the creative, original thinkers. My mentors, Dr. Marcus Meyer and Dr. Daniel Lescarton, are really smart, innovative thinkers, and really taught me to have interdisciplinary collaboration and critical thinking and challenging of the status quo. And the environment is just really ripe for this kind of grassroots study that involved lots of trainees. And so it was really fun to be a part of. And I should also mention that there is a trial that Medtronic is sponsoring called Elevate HFpEF, which is a little different than myPACE, but they're going to be putting pacemakers into patients with HFpEF that don't have a bradycardic pacing indication as a treatment strategy. And so I think a lot of valuable things will be gained from that study as well.
This is Dr. Robert Bonow at JAMA Cardiology, and I've been speaking with Dr. Margaret Infeld about clinical outcomes with personalized accelerated physiologic pacing in heart failure with preserved ejection fraction. You can find a link to the article in this episode's description. This episode was produced by Daniel Mosisi at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. Thanks for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.